Yep.
Good afternoon, everyone. Today is Friday, August 11th, and this is our United Medical live updates for the week of, again, this is Friday, August 11th. So Kamal is off this week on vacation. So we will be talking today on our clinical topic. So we do focus the second Tuesday, the second Friday of each month on our diabetes topic. So today we have with us Dr. Aparna Hosmane and Caroline Weber, our dietitian who runs the diabetes program, and we're going to be talking about eye health. So thank you both for joining us. I'm going to share my screen. So let's see. All right. Can you guys see my screen then?
Yes.
Okay. All right. So today we have, like I said, our diabetes program. So I'm just going to go through the slides. So our wellness program team consists of Kamal as our chairman and CEO of United Medical ACO. Myself, Donna Gunkel. I am the director of clinical integration and oversee our wellness programs as well as our other clinical programs. We have Dr. Ripu Handel, who is our director of the diabetes program and an endocrinologist in our UMACO. Caroline Weber, our lead dietitian for the diabetes program. And then we're also supported by our social workers, Roxana Portlock and Carla Williams. So again, this is just a quick overview of the program. So we do focus on many different aspects that do impact patients who have diabetes. We focus on endocrinology, cardiology, nephrology, podiatry, social work, physical therapy, eye health, and many others. And again, today we have Dr. Hosmane here with us from Hosmane Eye Care. So I am going to turn it over to you to introduce yourself and get us started.
All right. Good afternoon, everybody. I'm Dr. Hosmane. I am an optometrist on the United Medical ACO network. So a fair number of my patients do have diabetes. So we're going to talk a little bit today about how diabetes affects the eye. So we know that diabetes is a condition that affects a lot of people. 1.6 million Americans have diabetes. And then just as a little review, we classify diabetes now as type 1 and type 2. We used to say insulin dependent and non-insulin dependent. So type 1 used to be called insulin dependent. That's basically when the body does not produce insulin. Type 2, the body does produce insulin, but it's what's called as insulin resistant. So the body doesn't use it properly. Treatment for type 2 can be diet, exercise, medication, and then sometimes insulin as well. Diabetes is a leading cause of vision loss in people from 18 to 64 years worldwide, especially in developing countries. So it is something that certainly is very, very prevalent there. Next slide, please.
Sorry, there may be just a slight delay.
Okay.
There we go.
There we go. Okay. So we hear of a test called the A1C test, or it's hemoglobin A1C actually. So what is this test and why is it important? So it's important because it gives us kind of like a 3-month average of how blood sugar is working. And the mechanism behind a hemoglobin A1C test is hemoglobin is a protein that's on the red blood cell. And what happens is the sugar that's in the bloodstream kind of latches onto the hemoglobin, and the red blood cell is kind of carrying this hemoglobin with the blood sugar with it over a 3-month span, which is how long the blood sugar or the red blood cell usually lives. So it's a really good indication of the average. It's in a percentage normally. So normal A1C is usually below 5.7%. So the goal for diabetics, for the most part, should be below 7, but that will depend on what the A1C is to begin with, and then each doctor may have a different goal for each patient. But typically, it's something that's measured usually twice a year. Certainly, the higher the A1C, certainly the more a risk of complications, whether it's to the eye, to the kidney, feed, et cetera. So when my patients come in, I always like to ask, do you know what your A1C is? That way they know, have an idea of kind of how their readings are going. Even if their fasting blood sugar is good, even if their ranges are good, the A1C to me is really super important, because if it's high, then we know the blood sugar is really kind of up and down a lot. So knowing the A1C and getting it measured twice a year is really, really important. So diabetes can affect the eye in many different ways. We're going to kind of focus on retinopathy. So anything that affects the retina is called retinopathy. So we think of the retina like the back wall of the eye. And we'll talk about, what kind of changes we have, but we can have changes to the lens in the form of a cataract. We can have blood vessels that grow in different parts of the eye. We're going to have glaucoma that may happen. So diabetes is a risk factor for lots of different things involving eye health, but we're going to focus mostly on retinopathy. But here's a little bit of an overview of the anatomy of the eye there. So what is diabetic retinopathy? So what happens is that when we have that higher level of blood sugar, it starts to damage blood vessels in the back of the eye. These are very, very small blood vessels. They're capillaries, and they get damaged from that higher level of blood sugar. So they start to leak, they start to swell. Sometimes there's kind of these abnormal blood vessels that grow that are not normal. These blood vessels, because they're really, really thin, they will tend to break and bleed sometimes. So certainly the more we have going on in the back of the eye, the more symptoms we certainly have. So this is why it can be certainly a leading cause of blindness. But, it's interesting because sometimes someone can be diabetic and they can have changes going on in the back of the eye, but we don't necessarily see anything or feel anything different. So that's why it's really, really important to make sure we get our eyes checked. So someone who is a type 1 diabetic, they usually recommend within 5 years, they want to make sure that they have their eyes checked. If it's type 2 diagnosis, you want to get your eyes checked certainly at the time of diagnosis. So what are some of the things that you can notice in your vision? Now, again, sometimes you don't notice anything necessarily, but that doesn't mean there's not anything going on. But if you aren't having symptoms, especially, it's very important to get checked. So you can have anything from blurry vision. You can have actually vision that fluctuates actually. So if your blood sugar is up and down a lot, you can have your vision that's also kind of blurry sometimes and clear sometimes. You can have things like flashes of light, floating spots, missing piece of vision, and then certainly kind of the end stage there is just losing your vision completely, because you may have things like a detachment of the retina or bleeding that happens in the back of the eye. So as we were saying before, with the retinopathy, very often for type 1, because it's sometimes diagnosed a little bit earlier on, we don't always have retinopathy right away. So, usually within the first 5 years, we like to have that baseline eye exam done, just to make sure we check the back of the eye and make sure everything is healthy. For type 2, on the other hand, we may already have something going on, because that blood sugar may have been already elevated. Someone may have been pre-diabetic before they're truly diabetic. So we want to really make sure we get that eye exam done as soon as possible to when the diagnosis has been made. And of course, the longer you have this condition, the risk typically increases. And it's interesting because for my patients, even those that are really under very, very good control and tight control, once they cross that 15-year mark, give or take, I start to usually see something in the back of the eye anyway. So that's why it's really important to make sure we get that eye exam done, and a dilated eye exam done, so we take a good look at the back of the eye.
Dr. Hosmane, can I ask you a quick question here?
Sure.
Are there any tests that can be done besides the dilation? Like, I know sometimes they have different machines that I've had done where you don't have to have the dilation. And does that work as well for a patient with diabetes?
So that's a really good question. And of course, in this day and age, we have so much technology. We have all these different types of machines and tests that can be done. So, we can have just a picture done. I know at the clinic we had a retina view at one point that was taking pictures. So I think of those tests as, kind of more of a screening type of test. Simply because it is a flat image, so it's a really good screening test. We have tests, for example, that they do at the VA as well, that really screen a lot of patients. So I think it's a really good screening tool. But in my mind, nothing really takes the place of a full dilated eye exam, because we want to remember that the eye is a ball. So we want to look at the eye not only straight ahead, but we want to look at the eye all the way around as well. So while we have these really nice tools, in my mind, I feel like they don't necessarily completely become equivalent to that full dilated eye exam. But they're good tools to have, though.
Thank you. I just think it's important to make sure patients do understand, if they don't
Yeah.
have it dilated, but they went to the eye doctor, that may not be the same thing. So
Right.
just understanding the need for the full examination.
Yep. Completely agree, for sure. So what happens if we have these changes going on in the back of the eye? Now, if I see something in the back of the eye, that doesn't mean necessarily that we have to treat anything. So initially, I may see the patient a little bit more often, monitor the retinopathy. With the retinopathy, basically, if we think of it as, there's retinopathy that doesn't kind of leak or kind of bleed over time, and one that does. So certainly when we have especially these new blood vessels that can burst and things like that, then we have to intervene and send someone to the retinal specialist. So the retinal specialist at that point might do some injections. They may do laser, because the key here is we want to try to kind of preserve whatever retina's still remaining. We cannot necessarily undo what's already damaged, unfortunately. And even the lasers themselves, will cause certain changes. But the key here is to really try to preserve what's there. Can retinopathy get better? Sometimes I've had patients where, if they work a little harder and they do a little bit better, and I follow them after maybe 3 months or 4 months, sometimes I look back and say, hey, actually you're doing a little bit better, which is good. But the more retinopathy we have, it's probably going to stay there. So again, lasers, injection, the goal is to try to make sure we get that A1C headed in the right direction. That's going to be the key. So, we talked about the retinopathy, and part of what happens is we have an area in the eye that's called the macula. This is where our central vision is. And then sometimes we can actually have leakage and swelling in that particular part of our eye. And as we can imagine, if that happens, then our central vision is certainly going to be affected. So we don't really want to get to that stage where we have this macular edema happening. Again, that's where injections come in, steroids will come in. We can also have retinal detachment that happens, because remember those blood vessels we talked about, those really fine, delicate blood vessels, they grow in between the retina, which is the back wall of the eye, and the gel that's in front of the eye. And these blood vessels will tend to kind of be sandwiched in between, and then they will be pulled on. So when they get pulled on, then they start to bleed, and because they break, and then sometimes they bring the retina with them when they're being pulled. So that's where that retinal detachment comes from. So of course, if you ever notice things like a lot of light flashes, a missing piece of vision, we want to make sure that a retinal detachment has not happened. So this shows you a picture of an example of what the back of the eye can look like. So that central part, that little circle part there in the middle, kind of towards the right, is the optic nerve, and we have all these blood vessels, kind of radiating from it. That little red cherry spot, that's the macula that we were talking about earlier. So you see on the left, we have a nice, healthy, normal, a nice appearing retina. On the right-hand side, now we can start to see, unfortunately, a retinopathy that's happening. We can have, we see these hemorrhages happening. This person probably has, I would guess, maybe some changes related to blood pressure as well, because sometimes we can have retinopathy happening from both things, and there's a little bit of an overlap. They present slightly differently, but as we can see, there's a good amount of, unfortunately, leakage here, the little white changes in the middle. We see these hemorrhages happening. So especially again in that macular area. So pretty safe to say this person is probably not going to be seeing very well because of that change, especially in the area of the macula. So the one other thing also that can happen is what's called a cataract. Now, a cataract is when the lens that's inside our eye becomes cloudy. Everybody develops cataracts because they're caused by normal aging of the eye. They're also caused by the ultraviolet that's in the environment. But when we have that higher level of blood sugar, that blood sugar can end up kind of depositing in the lens. So it's going to cause that lens to become cloudy more quickly. So especially for folks that are not very well controlled, we're going to see cataracts earlier. They grow more quickly. And then also, if we don't take care of ourselves, if we smoke, if we don't wear sunglasses, if we are on steroid medications, these are all different things that are they're going to contribute to cataracts forming in the eye. Glaucoma is a condition where we have the optic nerve that's affected. So again, the diabetes is a risk factor for glaucoma. Now, the tricky thing about glaucoma, I tell my patients, is glaucoma, you don't necessarily see anything or feel anything different. So someone can have glaucoma, but we wouldn't really even know it. So that's why as part of a comprehensive eye exam, we always check the eye pressure to make sure that's okay. Again, these blood vessels that can grow can affect how the fluid in the front of the eye is drained and kind of clog things up, and that can also lead to certain types of glaucoma. So again, there's typically no pain. You don't have any symptoms. We hear about people losing their field of vision, but that is not something that happens right away. So if we're at that stage where we're noticing changes, then we already probably have some damage happening. But again, we want to screen for glaucoma as well when someone is diabetic. Again, this is just a little picture of, like a little infographic of what we talked about before. So on the right, you can see that cloudy lens there when someone has a cataract. Glaucoma. On the left, you can see on the on the right, the drainage canal is blocked, and that's because those blood vessels may be growing there. And then on the top left, again, we have that retinopathy, just like we saw in that real life picture, those cotton wool spots, those little aneurysms, those little beads in those blood vessels, hemorrhages, and then exudates as well. So, with diabetes, again, it's damage to the capillaries in the back of the eye. So I get asked quite a bit, how often should I get my eyes checked? Should I come in every year? So I tell my patients it is really, really important to come in at least once a year, sometimes more often, depending on what we have going on in the back of the eye. As we said before, in my mind, nothing really is equivalent to that dilation other than just the dilation itself. As most folks that are diabetic have probably gone through this process before, we just put some eye drops in, it opens up the pupil, and then it just allows me to get a really good view of the back of the eye. I always describe it like this. It's like I'm trying to look into a room through a keyhole. If my keyhole is really small, I don't see much of the room. But if I open up the keyhole, I see more of the room inside. So that's kind of the purpose of that dilation there. And again, it's all about prevention. It's all about preventative maintenance. So if we just do that eye exam once a year, we could catch things before it becomes too late. And as Donna mentioned before, a screening test and a photo, in my mind, again, is not a perfect substitute. So we want to really make sure we get that full comprehensive eye exam done. So with diabetes, there's certainly other things that certainly have to come into play as well. Again, most of my patients are not only diabetic, but they're hypertensive, they have high cholesterol. So, we have to maintain all these things. So, when I ask my patients, how's your blood sugar? I say, how's your blood pressure? How's your cholesterol? Have you seen your doctor? So seeing your doctor on a regular basis. And it's really a good idea to make sure, of course, we are aware of our numbers, right? So what are your fasting numbers like? Keep a log. Sunglasses are so easy to wear. It's very easy thing to do to keep your eyes healthy. Smoking is a risk factor for things eye related as well. Smoking is a risk factor for those cataracts, macular degeneration. So, not a good thing, in general, but it's one more thing that's going to be important to not do for our eye health. And I know Carolyn's going to talk a little bit about this as well, but I get asked all the time, what should I eat for my eyes? What's good? So anything that's, good for us anyway, brightly colored fruits and vegetables, green leafy vegetables, especially kale, spinach, collard greens, and, multivitamin lutein is always a good idea. For those patients that may be at a little bit more of a risk for eye diseases, I like to have them take a specific eye vitamin sometimes, but it does depend on their risk factors. They have a family history of any conditions like macular degeneration, for example. So it's kind of a number of different things that you want to do, but all these things put together are going to make sure that you keep your eyes healthy and hopefully lessen the likelihood of your eyes changing with the diabetes. And then I think, I'm not sure this is my last slide, but I think this was a nice little summary, like A, B, C, D, E. I like to use mnemonics a lot. I think my brain just works better that way. So I like this one a lot. I came across this one. So the A is for A1C, B is for blood pressure, C is for cholesterol, D is for don't smoke, and then E is for your eyes. Get your eyes examined once a year and a comprehensive eye exam, including your dilation.
Is this the last one? Or
Yeah.
is this?
So
Okay.
that was it. That was it. So now we'll move into the nutrition portion.
I'm just going to stop, if we don't mind, for just 1 second to see if you have any questions, Caroline, but I did have one more quick thing that I just wanted to mention. And I know it was on one of your slides, Dr. Hosmane, but kind of circling back so that patients put it all together, right? Because we do have a lot of different specialists who attend with us periodically. And one of the things I know Dr. Hundle mentions a lot is that patients can have like a high A1C of 12, of 15, and they don't know it because they don't feel anything, because it doesn't happen overnight, right? It happens over time and their body kind of adjusts to it. So I guess just remembering that, and you talked a lot about A1C, but just keeping that in mind for the patients. And also remembering, again, to get their eye exam done every year, not waiting for there to be changes. Like, oh, I'm fine, I don't need to go this year. Again, prevention. And I think that's a lot about what we like to talk through on our sessions, regardless of what specialists we have, is just really focusing on prevention.
Can I just add one more quick thing, if that's
Sure.
okay? So it's very interesting because I've had patients that have had really, really high A1Cs, and you would imagine and you would kind of expect that there'd be something going on in the back of the eye. And very interestingly enough, sometimes I see there's nothing on the retina, which is very, very interesting. But that doesn't mean there isn't something brewing under the surface. That's important. So just because someone comes in and says, oh, well, my A1C is really high, and I tell them, well, your retina looks good, but I say, don't get too excited because there may be something brewing. So that same patient, over time, when their A1C has actually come down, then everything comes to the surface, and then we actually see something on the surface of the retina. So, kind of going back to still want to go in and still want to be checked just to make sure that you're doing okay.
All right. Anything that you wanted to add, Caroline, before we jump into your slides?
I was curious if there's like always genetic components with diabetes. So if you see, multiple family members with diabetic retinopathy or any of these conditions, is it primarily also a really heavy genetic component?
Yes and no. I think there's so many factors that come into play. So I think, with a lot of things we have these days, I would imagine there's going to be some amount of a genetic component there, but it's not something that is kind of cause and effect, right? There's going to be so many different variables involved there. So I would say genetics is something that I always think about. Even it's interesting, even certain types of prescriptions tend to run in families, whether it's a lot of astigmatism sometimes, cataracts sometimes. So I think with eye health in general, there's definitely a genetic component there to some extent. So that definitely has to be kept in mind also, for sure.
All right, thank you. So I will reshare, and we will then move into the nutrition aspect for our session today.
Awesome. So we're going to talk about kind of all the foods that have benefits for eye health and diabetes management as well. We're going to focus on kind of food groups specifically, vitamins, where to find them, and then some patterns that are pretty consistent in helping prevent diabetes as well as supporting eye health too. So there are loads and loads and loads of studies that connect dietary habits with prevention and treatment of diabetic retinopathy. So going through kind of our first step in identifying the types of foods is fish and omega-3 fatty acids. So fish have been shown to do wonderful things because of those rich fatty acids that we see, the long chain omega-3 polyunsaturated fatty acids, PUFA or PUFA for short. But they're super protective because they're anti-inflammatory. So they're not only great for eye health, they're great for heart health, diabetes prevention. So they've got multiple factors and uses. There's a bunch of studies that kind of go, how much do you have a day? Usually it's determined around 500 milligrams per day of dietary omega-3s is recommended just to reduce the risk. Or 1 to 2 servings of fish, fatty fish per a week. So the first couple of fish like trout, eel, herring, tuna, those kind of reduce by 60% the risk of diabetic retinopathy when eaten on a regular basis. And then there are some really dark fatty fish that are really oily, like the salmon and mackerel, sardines. Those actually have a little bit more of an effect, like a 70% risk reduction. So including these fish regularly has shown a lot of benefits. But there is hope for those of us who don't like fish. There are some other food sources like chia seeds, flax seeds, walnuts that are really nice and easy to add on to your foods that you're already having. Yogurts, eggs, soy beverages, sometimes they're even added into fortified foods too. So there's a bunch of different food sources, but there's also supplementation. So talk to your provider, your dietitian, if none of these options sound appealing to you or just not a regular part of your diet. There are certain supplements we could recommend, but we always really approach it with a food first approach first. So with fish and omega-3 fatty acids, our next food groups that we're going to look at are fruits and vegetables, which we already touched on a little bit, which is great. Our main goal is color. We want lots and lots of color. Fresh fruit, canned and frozen, work just as fine. They still provide good nutrients as well. We just want to watch for added sugar if you're getting kind of the canned variety. But fruit rich in zeaxanthin, which I can never always pronounce that, but carotenoids called zeaxanthin and lutein are great carotenoid molecules, which you'll find in colored foods. So the word carotenoid kind of goes with that carrot, if you're thinking carrots, and if your parents ever told you to eat a lot of carrots to support your eye health, that is because they contain that carotenoid factor as well. Antioxidant properties, known for anti-inflammatory purposes. So really great protective nature of these foods. And it's a wide variety, right? So anything with green leafy vegetables, bright colors, peppers, oranges, bananas, honeydew melons. Even when we're kind of touching on, well, we want to manage our diabetes, so we don't want to overdo the fruit, still including some servings of fruit is very important, just because there are studies and research showing that it does decrease risk of complications with diabetes when eaten on a regular basis in moderation and portion sizes because of the vitamin and mineral factors and the protective nature that it provides. So we want to make sure we have good consumption of all these foods, kind of including them regularly in our diet. Now for the vitamins and minerals. So we know the food groups, kind of what we're searching for, but what are the specific vitamin and minerals that we're really looking to include in our diet? So we know that vitamin A is great. It helps protect the surface of the eye. It's beneficial for night vision, usually about 700 micrograms a day. It can vary based on your provider's recommendation. So we want to get vitamin A. We'll talk about sources in a moment. Vitamin B2, which is riboflavin, helps the retina receive light. So usually about 1 to 1.3 grams a day is recommended. We know vitamin C, it's not only great for immune health, but helps support that blood vessel through the body, including in the retina. So usually about 500 milligrams a day. We know you can't really overdo it. It's a water-soluble vitamin. You can't really overdo it. So usually if you're trying to support immune health, a little extra is perfectly fine. Vitamin D, we know it's protective for eye health and to heal injuries as well. So usually about 600 international units we would recommend, but we know that most adults in the US are pretty low in vitamin D. So if you're already supplementing or if you're interested in supplementing, because sometimes it can be a little difficult to get that vitamin D from food, talk to your provider about what is right for you. Lab work can be drawn to kind of see if you're already low in your vitamin D levels as well. Then we have our vitamin E, which is our antioxidant that protects the eye from damage. Usually about 400 IUs. It's a little on the higher side from your normal recommended amount. That's usually just for the eye protective. It's usually recommended if we're trying to focus specifically on protection for the eye. And then there are some studies about zinc and copper, not as many as the other vitamins, but there have been shown if you look at certain eye bites, you'll notice some of those minerals popping up, which is great. So including these specific vitamins in the types of foods that we're choosing can be super helpful for the eye. And we know that it's helpful for diabetes as well. So where do we find all these guys? All right, so our next slide will have kind of pictures of what we're looking for food-wise. Vitamin A, we're looking for all those bright orange colors, bright red colors. Basically, think of a carrot, think of that color, and go to that for vitamin A. So we see there's tomatoes, lemons, butternut squash, papaya, carrots, peppers. B2, you'll find mostly in meat products, fish and eggs, some in dairy and legumes as well. And then our vitamin C, you can think of citrus, papayas, peppers, spinach. You can find it in Brussels sprouts and broccoli. Vitamin D, you'll find mostly in dairy products, in your eggs, and in your fish products. Vitamin E, we're looking for some, like you could find it in oils, like specifically olive oil, nuts, legumes, certain green vegetables. And then your zinc and copper is mostly legumes, lentils, fish, and meat products that you're going to be searching for. So it's not that you have to go super hard and find one food and just overdose on that food, but it's more including a wide variety. So keeping variety in your body allows you to get a multitude of different vitamins and minerals and nutrients. So you don't have to worry about eating one specific. There's no such thing as a superfood, but it is helpful to include a wide variety so you're getting all of these vitamins and minerals. So now that we know the types of foods to eat, the vitamins we're focusing on, there are certain dietary patterns that I recommend, especially in counseling, we're focusing on specific things like diabetes, that encompass all of this. So you'll notice all of these foods we've talked about are included in the Mediterranean diet. So usually you find people on the coasts of bordering Mediterranean Sea who follow this diet. There's usually low risks of heart disease and diabetes. It's actually been shown in a lot of studies to reduce the risk of having diabetes, as well as being protective for all of these things because of its anti-inflammatory properties. Mostly focuses on those whole grains, focuses on those fruits, vegetables, fish, a little bit in moderation of that dairy product, and then limiting the refined sweets and keeping them for special occasions, really, which in all turn, these are the things we talk about for diabetes management too. So Mediterranean, it's not a restrictive diet. It's not even, hey, even saying a diet, it's a pattern of eating that we want to kind of include regularly. So if you're already including these foods, you may already be following kind of a Mediterranean-based diet. So our summary, just to wrap everything up, we want to focus on, we've said preventative many times today, and I totally agree with that, because we're consuming a well-rounded diet rich in fruits, vegetables, whole grains, lean proteins, healthy fats to ensure we get the protective effect of the vitamins and minerals to support our eye health and our diabetes management. But managing our blood sugar through diet, medication, and lifestyle changes, that is helpful in preventing it, all the complications, if we can prevent it, that's what we would love to do. So continuing up with regular providers for preventative care of eye exams, nutrition appointments, doctor's appointments, just to stay ahead of your health is really going to give you the best benefit. And that is my last slide.
All right. Thank you so much, Caroline. All right. Well, that was great information, I think, today. And it kind of goes a little beyond just the eye, right? But all the things that affect someone with diabetes, but can also affect their eyes. I thank you both for joining us. Are there any last comments or questions that you may have before we end our session today?
I should have mentioned, I actually recommend fish oil all the time to my patients. Because of exactly what Caroline said. Fish oil, like I tell my patients, good for heart health, good for eye health. And pretty much everybody these days also has dry eye because of screens, right? Pretty normal. And so fish oil is actually really good for dry eye also. It has those omega-3s, which are really good at counteracting inflammation. When we have dry eye, we have a lot of inflammation. So good for dry eye also, bonus.
Oh, that's great to know because
I'm all for fish oil. I'm all for fish oil. Recommend it all the time.
Great, great. All right. Well, we do again appreciate you joining us today. And thank you, everyone. I did just want to point out that we do have an array of resources out on our umusa.net website. So we will post this session as well, one of our webinars. We have all of them out there. We also have a wellness page under patients on umusa.net where we have, again, we have a lot of quick tips, we have a lot of handouts, and we have our videos. So we want to make sure that our patients are able to get information and utilize it in a way that helps them. So sometimes it may go, they may want to go back and listen to a particular session again and again. So thank you, everyone, and hope you have a great weekend.
Thank you.